Today we present a case of Vasa previa in a pregnant woman who came to our clinic around the 30th week of gestation. This is a rare obstetric condition, but potentially very serious, characterized by the presence of fetal blood vessels that cross or pass very close to the internal cervical OS within the amniotic membranes, but without the normal protection of the umbilical cord or placental parenchyma. In the images currently being shown, we can already see how the transvaginal study immediately confirmed the presence of Vasa previa. In fact, you can see this vessel passing directly in front of the internal cervical os. Generally speaking, two of the main causes are most commonly associated with this condition. Among these, we should mention velamentous cord insertion or a bilobed placenta, or one with accessory lobes. In our case, however, the placenta is normally inserted and does not have accessory lobes, but as we will see in the following images, it does show increased thickness. Moreover, sometimes the presence of Vasa previa can also be associated with a low-lying or previa placenta. However, in the case under examination, this is not present. The estimated incidence is 1 case per 2,000 to 2,500 births, although this figure varies greatly depending on the population and the studies. This condition is extremely dangerous because these fetal vessels, being unprotected and supported only by the amniotic membranes, can, in the event of membrane rupture or during labor, themselves rupture, which can, as a direct result, cause a rapid and severe fetal hemorrhage, which is a significant and sudden loss of blood from the fetus. This situation is potentially fatal for the fetus. Obviously, with ultrasound diagnosis, the prognosis has significantly improved over the years, especially when the examination is performed via the transvaginal route. From the images being shown, we can see the placenta, which, in addition to having an increased thickness, as previously mentioned, also presents venous lacunae that can already be seen even without color. Of course, with color Doppler, we can assist ourselves and visualize them even better. The thickness is found to be increased, and the study of the placenta is also performed transabdominally, where we can see even more clearly that the thickness is definitely increased. However, the placenta is not located in front of the internal cervical OS, and it presents these lacunae. Furthermore, with the transabdominal approach, we can see that in our case the cord insertion is paracentral and not velamentous, as is very often the case in Vasa previa. In addition to the position, we also examine the thickness as well as the myometrial thickness. In our case, as we can see from the images being shown, the myometrial thickness is reduced, reaching a minimum thickness of just 1.4 millimeters at one point. In fact, the presence of increased thickness and the presence of lacunae, in addition to this extremely thin myometrium, could be indicative of a creta. Clearly, however, the diagnosis is made. In fact, once this condition is diagnosed, the management of Vasa previa involves a careful plan to minimize risks to the fetus. First of all, regular monitoring must be carried out. In some high-risk cases, hospitalization is recommended, especially towards the end of pregnancy. And as a result, an elective cesarean section should be scheduled, usually between 34 and 37 weeks or earlier if there is a high risk, in case complications such as bleeding or preterm labor arise.